Hello, everyone. Good afternoon. Thank you for joining us for our webinar. We're going to let a couple more people quickly join while I run through some housekeeping items before we begin. Wanted to let you know that the presentation will be about 45 minutes long with 35 minutes of presentation and about 5 to 10 minutes of Q&A at the end. So please type your questions in the question portal. We're going to hold all of those questions till the end. And those questions are private, so no one else will see them except for the administrators and the presenters. There is also a chat function tab. If you have any technical issues or any other questions you'd like to ask us that's not pertaining to the content of the presentation, you can chat those, but please know that those questions are all going to be public. So the chat questions are public, but the actual questions tab is private to us. Also, there will be some poll questions I'm going to put out throughout the presentation regarding your interests, regarding the content of the talk. So feel free to answer those. That just helps give us some more data about our audience members. Also, this session will be recorded, and we'll be sending this out following the session in about an hour or so afterwards. So you will get a recording link to watch this and hold on to and share with your colleagues. So thank you again for joining. This content is international and domestic second opinion consultation through digital pathology with our speakers, Dr. Jianyu Rao and Priya Vaidyanathan, about this webinar. So the increase in cancer rates, shortage of pathologists, and limited resources in remote areas create a global burden on the pathology system. In this webinar, we'll discuss how the UCLA Health system established an international telepathology system to aid pathologists and patients in China. We'll also discuss how new technologies such as OptraSCAN On-Demand Digital Pathology can enable international and domestic telepathology networks to attain lower turnaround times for secondary consults, remote frozen sections review, and better overall outcomes for pathologists and patients. And we're going to turn it over to Dr. Rao to get started.
Good morning, everyone. Thank you, Jennifer, and thanks OptraSCAN to give me the opportunity to share with you our projects and experience of using digital pathology to provide international second opinion consultations for the pathology cases. So these are the objectives of this discussion today. First of all, I'd like to just to go quickly review some of the basic components of digital pathology. But my discussion will be mostly focused on our experience and our projects on the international second opinion consultation using the digital pathology. And I will discuss why we do it and how do we do it, and also what are the challenges and potential solutions that we have been facing, and also very briefly touch the other potential applications of the digital pathology in the pathology practice. First of all, I'd like to just to say that I don't have anything to disclose for this particular project. The definition of telepathology, I think, is best provided by the American Telemedicine Association 2014, and says that a form of communication between medical professionals that includes the transmission of pathology images and clinical information for the purpose of a variety of pathology practice, including primary diagnosis, rapid cytology interpretation, interruptive and second opinion consultation, ancillary study, and so on. Now, as far as the digital pathology, as we all know, it involves in computer technologies, or most of the time is the whole slide imaging to convert the analog images into the digital images. The system typically requires, as usual, the microscope, camera, scanner, computer, and monitor, but also the software. The procedure involves in imaging acquisitions, processing, archiving, and retrieval. And I think, as you can probably see from this slide, that on the left side shows the regular procedures for usual microscopic review of the imaging, but on the right side, just adding the scanner and software really is the main component for the digital pathology. There's many potential applications that we have been witnessed for the utilizing digital pathology in our practice. Before April 2017, I think most of the practices focus on second evaluations, adequacy, and storage and so forth. But I think, as you probably all know, that there's a major development this year in April, that FDA approved the marketing of the Philips PIPS system for this whole slide imaging for the primary review of the biopsy tissue sections. And this is a major event that has potentially quite a bit of impact in our practice. I think for the impact for the industry is that others may only require 510K for the future applicants. But to my mind, I'm more consider the impact for our pathology practice, which means that we may have to think about signing out cases even when we take showers. So that's good or bad, depends on how you view it. And at the end of the day, I think this will eventually move the field of computational pathology forward. So it's a big step forward. And that's kind of the basic discussions that I'd like to stop here to switch my discussion to why we are doing these projects in the international setting. One thing that you probably will you didn't realize in this country is that how other countries really have to face the problem of shortage of pathologists. And let me just give you some numbers. In US and Canada, the estimate is that we have about 4 pathologists per 100,000. In China, which is about 1.36 billion people, that's like 10 times less. So they have like 0.6 per 100,000. And if you talk about the cytology and other subspecialties, this problem is much worse. So that's a big difference in terms of number. I think the problem is not limited in China, but other Asian countries as well. But on the other hand, there's a big increase of cancer problem and other chronic disease as well. For cancers that we've seen a increase of not only the usual type of cancers that are associated with the developing world, which is like gastric cancers and liver cancers, but other so-called cancers that are associated with developed countries like breast cancer, prostate, and colon also increasing. So there's tremendous problem that facing the country for the dealing with cancer issue. And the importance of the pathology diagnosis can be highlighted by looking at some of the statistics. And if you only focus on this one cancer type, which is cervical cancer, which is the blue line, you can see the difference between China and the USA for these particular cancers. And cervical cancer in this country is very rare, and there's hardly any invasive cancers we see nowadays. But in China, they are actually increasing, as you can see from this line. So, of course, there are multiple factors involved, but one of the key events that makes the difference is that the screening practice is limited, and that has to do with the fact that there's a limited cytologist who can read past meals. And of course, you can say, maybe HPV vaccine and which HPV testing can make a difference, but still, the cytopathology contribution is very important for the screening, regardless whether you have HPV testing available or not. So our project started from 2010. At the time when the 2 universities, UCLA and Zhejiang University, which is a very top university in China, decided to move from not only the research and educational collaboration, but to expand that into the medical field. But as you all know, that medical collaboration between countries is much more difficult. So one place that we decided to start is to look at the pathology and doing telepathology using technology like digital means. And so we had a first contact in May 2010, and actual event started from 2010 October. And this is the inaugural event that shows the first case discussion we had with the counterpart between our institute and the Zhejiang University second affiliated hospital. Actually, this event was highlighted when at the time Chinese President Hu Jintao came to U.S. To visit White House, meet with Obama, and they highlighted our project as one of the success of clinical collaborations between scientific collaborations between the two countries. So a bit of overview. So we started from late September 2010, and initially our projects used the Imperial platform. We're still using the Imperial scanner until today, and that platform from Imperial was switched to PathXL in 2014, and up to now we have about 3,000 cases. And I'd like to just to say that initial projects with Imperial really get a lot of help from the Imperial people, and they helps tremendously in our technological barriers that we have to overcome. So this is just to shows the components that we have nowadays for the project. It looks very technologically very complicated, but actually it's very straightforward. So this is the end that at their second affiliated hospital, which has the Leica scanner and upload the images into the server locally, and then the image will be replicated and eventually pulled through the SFTP into our local PathXL server, and from there, then we can access the image and start to review the case. This is how after we receive the image accession, we have a central accession personnel who helps to divide the cases, helps the accession the cases, and again then provide it to our junior attendings and fellows. They will take a look first and assign that to different specialties. We are having a subspecialty system in our institution, so the cases will be divided up into different specialty based on the nature of the case. This is just a few images of the our actual telepathology suite, and the server is actually stationed in our suite, and here's the central office that hosting our administrators and also the fellows who are handling the case as the gate person. And then this is the bird view of the entire office. And here's my office. Actually, is one of the 6 pathology offices that involve in the telepathology administration. This shows the our Chinese files that highlights our projects, and now we have more than one institute that working with us. We have actually multiple sites that join in as our network. This kind of approach has some positive and negative natures as usual. The workflow is very similar to getting a consultation cases from just the nearby Bakesphere or other places. The only difference is that now we are looking at imaging rather than glass slides. The one problem then is that the imaging system that we reviewed has to go through the PathXL, and that's not integrated into our LIS system. One thing that I hate most is that I keep forgetting my password, and because if I don't do this on every day, and the password is very long, and that's always the challenge for me. One advantage is that the whole system is very robust, so there's very limited administrative overhead. The other advantage is that it's a closed system, and so there's no, it's a very secure in a way, which is very important in today's age. This is just to summarize the case that we had over till last year. We're still 1 month away from the 2017, so we don't have the number for this year yet. But I can tell you that we are getting about close to 3,000 overall, and also shows the cases that from different organ system. Most of the cases are seen in cytology and GYN and soft tissue bone and neuro. So neuro is actually one of the major ones that we get in. one thing that I like to share with you is the turnaround time issue. Initially, when we first started, it takes about 4.5 days in average for the case to sign out. But now, after 2 years, we really can get down to 1 or 2 days. And that's a very critical component of the telepathology practice. So for some of the cases, we actually get in the glass slides to review, and most of the cases, so altogether about 15%, but most of them has to do with the fact that our hematopathology people really likes to look at the original slides. So we usually will ask them to send us the slides if they are lymphoma or leukemia biopsies. But the other 10% actually is for our QC purpose. We do kind of like biannual review for the cases, which I randomly select 10% of the cases for us to review, and with the 6 months minimum washout period. And over the years, we only see 2 cases that really shows the significant discordance between the actual slide review and the imaging review, excuse me. So this is one of them. And initially, the whole slide imaging case we called osteosarcoma, which, is reasonable, even though I'm not bone soft tissue pathologist. I can say, there's definitely spindle cells surrounding those like osteomaterials. So this was signed out as the high-grade osteosarcoma by digital pathology. But then when we look at the actual slides, our bone soft tissue pathologist decided to call this one actually a angiosarcoma. So that's one difference that makes that we still try to understand why we have such a discordance. But that's one of the cases that shows the difference between the diagnostic category of cancer. The other case that is this biopsy, which is the duodenal polyp, initially was called low-grade dysplasia. We see mostly low-grade dysplasia with these fragments that we consider for high-grade dysplasia. So with the imaging review, we call this one focal high-grade dysplasia. But actually, when we look at the actual slides, there seems to be no high-grade dysplasia. So that's one thing that we learned, is that the digital imaging may have problem with the distinguishing low from high-grade dysplasia, which I think also others had the same experience, and we will discuss a little bit later more. So one of the challenges that we see through our practice is that there's a difference of the healthcare system and culture that's very important to be considered when we doing this in the international setting. The patient history clinical information can be very hard to be translated into accurate English, so we have to be make a very extra effort on that. The internet access is always the issue, but we figure out ways to overcome that, and also the turnaround time. So those are the major challenges that we have to face. Now, the way that we deal with this, number one, that we have to make sure that we get enough case volumes. And this can be either from a single institution or from multiple institutions. The other critical component that we have to adapt to make sure that we can do this properly is that we do need to get help from the other departments, radiology, oncology, to really work together to show that the benefit of the collaboration is not limited on pathology. I think the most single important thing, if you ask me about what is the critical component to make this successful, is the leadership support. And of course, support from others, including our pathologists as well. So currently we are expanding these programs into many other institutions, not only public institutions, but private. For example, one of the major private hospitals in China is the United Family, which is started by an American, very fascinating lady who did this project about 93, and now it's a big network of private practice in China and other hospitals in China as well. So there's multiple institutes that involves in our projects. And one thing that we feel that is really benefiting is that the academic collaborations and trainings are really helpful. And also, we really have helped the institutions in China to start the new diagnostic modalities, for example, FNA of the thyroid and pancreas and so on. So the benefit is not limited only on single patient care, but actually expanded to many other areas as well. So that's pretty much what I have from our end. And there are a lot of stories that we can tell, but because of the time, but I'd like to switch the discussions to share with you some of the data that we have seen from other institutions. But the first one I'd like to share with you is obviously our friends from UPMC that did a lot of work in China as well. And they summarized their experience with the company called KimMed. So what they have seen is quite fascinating. And out of 855 cases they reviewed, and significant amount of the cases show difference in the diagnosis between the primary institution and UPMC. Actually, it's almost over 50%. We haven't summarized this way, but our number seems to be a little bit low. But this is tremendously significant finding. The other applications that I'd like to share with you is one of which is mostly related to cytology practice from WashU, and other one also is from cytology practice from Sloan Kettering. This project from WashU really shows the benefit of digital pathology that can really helps to do the rapid assessment with the EBUS FNA of the lung. With their application of the digital pathology, they can reduce the number of needles that needed, needle passes that needed for the procedure, and also reduce the number of slides that you needed for the procedure. And also, they found a significant decrease of the time that is needed for the procedure, as well as the results confirmation time as well. So there's significant efficiencies that you can see, but overall cost is not increased. So that's a very interesting results. Similarly, the friends from Sloan Kettering, Dr. Oscar Lin's group, shared their experience, and their study shows that digital pathology actually has high concordance rate compared to slide review in making adequacy and as well as the rapid assessment. Sorry, excuse me. So the study actually highlights very few cases that shows difference in the actual slide review versus the imaging review. As far as the frozen sections, the study from there's very limited study, but one of the studies from Boyle's group shows results from 70 cases, and only very few of them showed, like 1.4% showed some minor differences. I mean, showed major differences, but 2 is minor discrepancies, and the major differences mostly has to do with the dysplasia. So from severe dysplasia to the mild dysplasia. So this is much similar to what we have experienced in our institution on the international setting. And most recent studies from Europe, Dr. Vaidyanathan's group, that was just published in Archive Pathology and Lab Medicine, really show the issues that we have to deal with the digital pathology review. So they studied 23 studies and overall 8,000 comparisons between glass slides and digital images. And they found overall about 4% discordance. So that's about 335 instances. And most of that has to do with the problems of grading of dysplasia. So the bottom line is that the digital pathology overall for the histopathological setting seems to be working well for the diagnosis, but one have to take into account the challenges that you have to consider when you look at the grading of the dysplasia, which is very important point. So I'd like to just to summarize our discussion. So international telepathology using digital means is a very effective and valuable tool, not only for second opinion consultations, but in also stimulating academic collaborations and also other projects that in medicine in general. The successful application of the project requires really a coordinated effort, and it really needs support from the leaderships and all the peoples involved, especially the IT team. The importance of the systematic quality assurance measure has to be in place, and this really there's a range of steps that you have to consider the quality assurance, not only from the pathology review, but from the information translations from one language to another, which is very critical for the success. As I mentioned to you also, not only for the second opinion consultation, but telepathology can be used for many other clinical settings as well. But I didn't really have a chance to talk about the meaning of the artificial intelligence in our pathology practice. But I think we all can expect something happens in the future. I think, as you probably know, now the AlphaZero even beat the AlphaGo. So what happened for the next step? Everybody's looking at pathology, and I'm actually not scared about it, but I'm actually excited, because I think this can be a tool for us. So we are not using that against us. We have to use that to help us in our practice. With that, I'd like to stop my presentation, but I have to thank my entire department for the projects, but also people at our partner institution, the second affiliated hospital, Zhejiang University, really worked very creatively for these projects. So with that, I'd like to stop here and thank you for your attention. Hello?
So thank you, Dr. Rao. This is Priya with the OptraSCAN company. For the questions, we can take the questions towards the end of the session. So anything that you may have specific to the presentation that was given by Dr. Rao, we can take them towards the end and then answer them accordingly in the essence of time. Let me go ahead and share my screen as well. So today I'll be talking briefly about the offerings, the different solutions that OptraSCAN provides, and how do we differentiate ourselves in the market in the field of digital pathology. Our mantra is all about on-demand. We are all geared towards making digital pathology more affordable so that you're not really compromising on the workflow, the fact that the turnaround time, the quality of images that are being assessed by the different pathologists, the patient outcomes, all of these become affordable. So clinical situations, academia, reference labs, pharmacists, everybody can adopt digital pathology across the world and then be able to continue fulfilling the patient requirements without affecting their regular workflow itself. So with OptraSCAN, we do have scanners. We have a variety of the scanners, starting with our OS15, which can handle 15 slides, to a high volume scanner. We also have a dedicated unit to handle frozen section. And then, of course, the fluorescent slide as well, which can support up to 5 filters. These are all customizable to a certain extent as the need demands. In terms of the software solutions, we have ImagePath, which is a data management software, which handles cases, can let you do offline sharing as well. Telepathology, which is more in line with what Dr. Rao just mentioned. So ImagePath and Telepath in combination will let you share cases and slides with other consultants, either within the country or across the globe, to be able to get second opinion, to be able to do secondary consultation as a need requires. There is CloudPath as well, which is our laboratory information management system. And then OptraAssays, which lets you perform image analysis on these complicated images as well. So going further with OptraScan's ImagePath, as I mentioned, it's our web-based image viewing and case management system. There is a role-based scenario where you have histotechnicians who will be uploading the cases. They will be assigning slides to the cases and entering any metadata associated with it. At the same time, the pathologist can log in. They can see the cases that have been assigned to them. There is no geographical limitation to that. So the pathologist, the secondary pathologist, could be remotely located anywhere in the world. And then you should be able to see the data that has been entered in. So the pathologist can see the cases, the associated metadata, and the images associated with it. So this is just a mock-up of how the image looks, or what the screenshot would look like in ImagePath where the case is assigned. You can define if the case is a referral, if it's an active case, if it's an archived case, or if it's a closed case, or a case that requires additional tests. Telepathology, as mentioned, it's a mobile application, which you can have it on your mobile app, on iPads or iPhones, and it lets you have online consultation with any other pathologist. So you can select a pathologist who's remotely located or could be a guest pathologist. You can invite them for an online conference. You can share the existing case in hand and get the opinion immediately. So there is an offline mode and there's an online mode for immediate requirements. And there again, all of these are tagged in ImagePath, so you can see there is an audit trail associated with that as well. So you can see when it was initiated, which case was referred to it, and how many participants were there. So it's completely integrated with ImagePath. There is no additional licensing required. There is no additional installation required. Everything can be shared. Multiple participants can be part of that telepathology conference. So the next one, as I mentioned, the same ImagePath and Telepathology are available as mobility viewers as well. So whether you are on your desktop or a laptop or on your mobile device, any Android or iOS, these are all supported, completely supported. As long as the Wi-Fi is having a good connection, your internet connection is good, you will be able to see, the images. Go ahead and reshare my screen in case there is a glitch. And then finally, about the frozen section. So I briefly mentioned it in the beginning, along with the rest of our scanner suite. So this is new to our generation, new to our product portfolio offering, and it is catered towards handling frozen section slides and fine needle aspiration workflow itself. So there's a live view application. You can move it around. You can see the actual slide under the objective. And if there is a preference, you can either take a snapshot or you can command the slide to be completely scanned for a whole slide analysis itself, or a whole slide scan. So that would be more like a bright field scanning, but with the ability to do live viewing prior to that. You can switch. The frozen section unit itself can accommodate up to 7 slides. So the 7th slide is to cater to the wet slides or the improper cover slip because they are not still fixed yet. So this is catering to that entire surgical path or frozen section workflow itself. And then just to reiterate the telepathology portion of it, as I mentioned, in case it was missed in the beginning, these are our software solutions for ImagePath and telepathology. ImagePath is our image management and data management system solution, and telepathology is our mobile app viewing itself. So this is what ImagePath would look like. You have cases, you have slides associated with the cases, any conferences that have been assigned or initiated. And then this is the actual case viewing itself with any diagnostic reports, any clinical history, metadata associated with the case. These are all compliant, 21 Part CFR 11 compliant. This is just a markup of how the case looks. So as I mentioned, the case status can be changed from active to archived to closed or referral and so on and so forth. So it makes the life of the pathologist easier. And then this is the Telepath app. So this again, in case you are having trouble viewing my slides, or if there's a static which doesn't let you see my slides, there will be a video recording of it. So you will be able to see the video recording, and also the slides will be shared. The slides which are presented today, they will be shared with the participants. So you can have a look at the content of the material that was shared today. So this again is the Optra Telepath offering, which lets you share your case or cases online real time with multiple participants. And then finally, this is the mobility viewer, which lets you share your case either via image path or via telepath on your desktop or on your mobile device. So with that, I would like to end my presentation as well. For any questions, you can contact OptraSCAN for additional product information, for any further detail if there is an interest on any of the product offerings as well. So at this point, I would like to open up the platform for any questions that you may have. I'll be taking off the viewing so that I can see what the questions are. And we can open it up for any questions if you can enter it in the questions window or in the chat window. So I have one question which says, how many slides were scanned for each case in an average, and were these IHC primarily for the consultation? Dr. Rao, that would be for you if you would like to take it up.
Okay, can you hear me okay?
Yes.
Yeah, I think this question is from Dr. Chen. Yes, so very good question. You know, we do have that data, but we haven't formulated the analysis yet. So it's variable from any case like 1 slide to 35 slides. Like yesterday, I had a case that is coming with like 35 slides, but most of the cytology cases are just 1 or 2 slides. So the immuno slides can be just like, you know, regular HE or pap stain slides, just to scan it in. And actually, the case from yesterday with 35 slides, I think more than 20 for the immunos. So yeah, so that can be a quite a variable from case by case.
So I hope that answered the question. Another question is regarding the consultation itself. Were there situations where you had real-time consultation versus offline case sharing with the associated metadata?
Yes, real-time consultation happens when over the years, but not quite often, but only like a few times a year. Typically, for the international setting, there's a big problem in terms of the time difference. So we done that when they need the like frozen consultations, and typically we have to coordinate the time, and that's usually, you know, their morning, which is like 7:30 to 9:30, and out here is like late afternoon, 4:30 to 6:30. So yeah, we did that a few times for the real-time consultation, but not very often.
Thank you, Dr. Rao. Another question. So for this kind of teleconsultation project and the layout, was there any prior experiment or setup required wherein the participating pathologists had to do a concordance study or maybe a brief concordance experiment for the same set of slides as a precursor?
Yes, we always do the, well, there are actually quite a few steps that we have to take to really make sure everything functional and smooth. One thing that we do is we actually make sure that they can, you know, stain the slides, and especially immunostains to have the quality that met our standard. and that's very important because if you have a very unreliable staining, that will cause problem. The other is that before we start, we always do at least 10 cases to validate the process. So we scan in the 10 cases and then review the actual slides and see if they are concordant. So that is kind of the quality steps that we have to take. There's a lot of things that I didn't have time to talk about, like, for example, report translation. I actually also do 10% QA/QCs to make sure that they are accurate and the randomly selected cases. So, but yes, before we start, we do have to do a lot of testing steps to make sure everything's functional.
Thank you, Dr. Rao. Again, I hope that answered the question. Another question is about the digital pathology application itself. Where do you see it in frozen section analysis while there is an ongoing surgery and that requires tissue analysis?
Right. Well, again, this is a very interesting experience that I'd like to share before I answer the question. Like the institute that we worked with in China, they do about 2,000 thyroidectomies a year. Sometimes even this year, I heard the number is even more. So they always do frozens on their thyroid, and we told them, they shouldn't do it because they have a good FNA service. So we helped them to do the FNA, set up the FNA. So that request is substantially decreased, but they still do sometimes request frozen. So in general, yes, the frozen should be only reserved for like certain areas. But the problem is that in many of these places that have limited pathology support, the practices still pretty much rely on frozen section, and that really, kind of vicious cycle, basically, that makes more demand for pathology. But my personal experience with this international pathology is that, if you use this for frozen section setting, the logistics issue would be tremendous. And I think the main problem that we have seen experience is the time zone difference, but there are others as well. If you do this locally, that may be a less issue. That's not necessarily a major problem, but at least if you do this close continental, the logistics are very challenging to deal with.
That was a very good insight, Dr. Rao, about that. That has always been one of the questions that kept, going back and forth regarding the use of frozen section in teleconsultation as well.
Right.
One other question that came about the neuro cases as well is, did the UCLA neuropathologist have the opportunity to review the MRI or CT images as well in reviewing those cases?
Again, a very good question. So the neuropathologist and sometimes bone soft tissue pathologist really wants to review the radiological imaging, and we do have a few cases that we really have to ask them to, upload the images for that. Yes, so they do have the opportunity to do that, and we will be able to, especially for the neuro and bone soft tissue people, they have chance to review the radiological findings as well. But unfortunately, our teleradiology, actually, we tried, but still not working very well. That just highlights that the issues that we always talk about. Technology may be one thing, but actual implementation can be different. And we have a lot of stories to tell why we are not doing well with teleradiology, but that's probably a different topic. So I'm not going to spend too much time on that.
Dr. Rao, one more question in terms of lymph-vascular invasion. Any comments on that, on margins and lymph-vascular invasion?
Yes, if I get a cases that are large specimens that they do provide, typically I would comment, but generally I sometimes will always put a comment that and this is the digital review, and please relay to the primary pathology report for additional diagnostic information, because they will put in questions for us, but they may not, submit the entire thing. So, so I always make sure that that as a second consultation that I'm covered. So, so we will always put a comment that they have to look at the primary diagnostic, from their own institution for additional information like lymphovascular or margins or staging information as well.
Okay, I had one last question that just popped up is, in terms of the secondary pathologists or the consulting pathologists, do they have to be identified early on, or can they just join in as guest pathologists and provide their opinion as well?
Yes. So this is a good question again. Not everybody's comfortable with the digital review. So we do give the option to our colleagues here that if they really don't feel comfortable or they don't want to get into it, that's fine. Typically, we assign cases to whoever's on service on that subspecialty that particular week or day. But if they don't, they are not involved, then we will assign that to a different person. So we don't really have a sort of like a qualification assessment before we review. It's just based on their own sort of comfort in a level.
Sure, that's totally understandable. And I think it's more like work in progress as more people get comfortable with digital pathology and see the potential behind it, and also get away from that traditional workflow. There'll be more participation, I guess.
Yeah. So I see another question about the logistics, and this is from Dr. Washington. So that's, again, very good question. And we really spent an entire 2 and 3 years to deal with the firewall issue. And I have to say the firewall issue, obviously, is not just in China, but actually, our UCLA own system as well. So, so both ends has this big firewall, so we have to deal with it. And that's why we do this kind of logistics, transferring images and upload it, and eventually, access locally.
Sure. And then one more question just came in, is about how are the pathologists comfortable with digital pathology and the distance? I think this you did previously answer. But
I think, again, this is the assessment you have to do before you start. Make sure that you are comfortable with those technique. And in our particular setting, because they are academic institutions, so we do really have a lot of exchanging beforehand. We send our peoples to locally to make sure that we train them, make sure the qualities meet our standard. And sometimes they send their people, technical people, to our institutions to learn how to do things. So you do have to make sure that that component is reliable before you actually start.
Definitely goes a long way as well. Yeah. So considering that we are coming to the close of the session, I would definitely like to extend my big thank from myself and from all of the participants to Dr. Rao. Thank you so much for your time and for sharing your experience in digital and telepathology. For participants, if you have additional questions, you have our email, you can send it to us and we'll answer them as the questions arise. These decks and the recording will be shared with the participants once the session is over. So thank you all for your time. Good day and good evening, depending on where you are located. Have a great day.
Thank you.
Thank you, everyone.